Welcome to our workshop about inclusive healthcare for people with intellectual disability. We would like to start with an acknowledgement of country. The acknowledgement uses plain English and was co-produced with colleagues with intellectual disability, as well as First Nations people. Over to you, Manon.
We know we are on Aboriginal land. We respect the Aboriginal people from this land. On this land, we live, work, play, swim, and dream. Aboriginal people have lived on this land for many years, and now we live on this land together. We respect all Aboriginal people and elders. We respect all Aboriginal people and elders who have lived in the past. We can learn a lot from all their stories, and we can learn a lot from each other. Now I'll introduce us. My name is Manon. I am a project worker. This is David. David is an inclusion project officer. David and I will present together in our workshops. We don't just talk about accessibility, we try to model it. For example, we use plain English and simple slides. Over to you, David.
The Council for Intellectual Disability, or CID, is a disability rights organisation. We've been led by people with intellectual disability for 70 years. We speak up on the big issues, we provide information and learning opportunities, and we empower individuals and communities. The name of the project that Manon and I work on is Just Include Me. The project receives funding from the Australian Government Department of Health, Disability and Ageing. This principle, Just Include Me, is fundamental to respecting people with intellectual disabilities' right to good healthcare and to good health. CID is proud to be a member of the National Centre of Excellence in Intellectual Disability Health, which works to ensure that every person with intellectual disability in Australia gets high-quality healthcare. You can find a link to the Centre of Excellence website at the bottom of this video. At the Council for Intellectual Disability, we believe that the voices of people with lived experience hold the wisdom that leads to positive change. So Manon, what will we talk about in the workshop?
We will talk about healthcare and inclusion. I will tell stories about my experiences, and we'll also hear other people's stories. We will focus on person-centered practice, inclusive communication, reasonable adjustments, and decision-making and consent. We will link each topic to CID's resources and online training, which is called the Just Include Me eLearning. The resources and eLearning are free. Over to you, David.
The eLearning and resources were created using co-production, which means that people with intellectual disability were involved at every stage. We also consulted with families, carers, and subject matter experts. Today's workshop is not about abuse and neglect, but before we begin, we need to talk about abuse and neglect. People with intellectual disability are much more likely to experience abuse and neglect than other people in the community. We all have a responsibility to respond. If you suspect that a person with intellectual disability is experiencing abuse or neglect, you need to take action. The steps to take are: 1. In an emergency or if there's immediate risk of harm, call 000. 2. Follow your organisation's policies and procedures and speak to a supervisor about the situation. 3. If appropriate, contact the National Disability Abuse and Neglect Hotline on 1800 880 052. 4. If appropriate, contact the New South Wales Ageing and Disability Abuse Helpline on 1800 628 221. You can find links to the phone lines at the bottom of this video. They can assist with referrals and next steps. Now let's start the workshop. So Manon, what's your experience as a person with intellectual disability when you engage with the healthcare system?
I've had both good and bad experiences. Health professionals are often not trained and may not understand how to work with people with disability. Sometimes I feel that lack of time is a big factor. It can lead to accidentally dismissing someone's medical needs. Maybe doctors feel they don't have time to sit and explain. Sometimes I've had doctors listen and help as best they can, and sometimes information is not communicated in the best way. For example, I've been in waiting rooms that have too much information, too many signs on the walls. This is especially hard when they are about daunting health topics. But some waiting rooms are better, open with more space and light. It's good to go into the doctor's office and have the option to record so that the information is clear and available for later. It also means that the doctor is free to be engaged and listening closely. Over to you, David.
Thank you for sharing your experience, Manon. Now let's look at what research shows us about health and healthcare for Australians with intellectual disability. According to specialists from the Australian Association on Developmental Disability Medicine, people with intellectual disability have poorer health outcomes than the general population. Over to you, Manon.
This includes more than twice the rate of potentially avoidable deaths, on average dying up to 27 years earlier than the general population, high rates of undiagnosed and poorly treated complex health conditions, low rates of preventative health care, high rates of mental illness and people cannot get the right help, more than twice the rate of hospital admissions. And sometimes the signs of illness are not so clear. All of which is why we need to get better at ensuring that people with intellectual disability receive the quality health care they need and have a right to, like everyone else in Australia. You can find a link to this research at the bottom of this video. Let's talk about practice of providing healthcare. We'll start by hearing from our team member Leonie, sharing an experience of poor practice related to her disability.
When I was admitted to hospital, I told them that I had an intellectual disability. I said, do not use jargon. I'd like to be treated as a normal person. The day after I had surgery, I was a bit scoobie. Scoobie means I was feeling unwell and shaky. The nurse brought me some pills. The pills didn't look right. They were not my medication. I said, no, I'm not putting them into my mouth. The nurse said I had to take these medications. They said that if I didn't take them, they would have to call the pharmacist or the surgeon to make me take them. Then I said, no, I don't want to take them. I ended up taking the pills. They started looking into why I wouldn't take them. It turned out that when I was taken to emergency, they were handed the wrong medication list. My partner's name is Leonard. They said to me, are you Leonard or Leonie? I said, I definitely don't look like a boy. In the end, the doctor said, there has been a mix-up with your medication. We are sorry. They had given me my partner's medication. There could have been side effects. I said, am I going to die? They said, you pulled through the operation. You haven't died yet. This would not have happened if they had listened to me. They should have just said, can you tell me your name? The nurse apologised and said, I wish I had realised and took your word.
Unfortunately, Leonie's story reflects common healthcare experiences for people with intellectual disability. The same research from the Australian Association on Developmental Disability Medicine identified these challenges that are impediments to person-centred practice. There are gaps in accessible, inclusive, and effective communication. There are gaps in the provision of reasonable adjustments before, during, and after seeing a person with intellectual disability. People experience stigma and unconscious bias, which affects people with intellectual disability receiving support to make decisions and having control over their own health. And there can be misunderstanding of behaviours of concern leading to diagnostic overshadowing.
We have a question for you. What challenges do you face when practicing with people with intellectual disability. You can pause this video while you reflect. For the rest of the workshop, we want to talk about the positives. We want to talk about what you can do in your practice. We know that health professionals work really hard to care for everyone, and we value what you do. We know that you are watching this workshop because you want to do the best for people with intellectual disability. You can be a champion for rights, health, and healthcare for people with intellectual disability. We want to talk about best person-centered practice. Over to you, David.
We will talk about the elements of best practice, which are to communicate in a way that's accessible and inclusive, to recognize behavior as communication, to make reasonable adjustments, and to support decision-making and seek consent. Much of what we talk about corresponds with the National Safety and Quality Health Service standards for the healthcare of people with intellectual disability. You can find a link to the standards user guide at the bottom of this video. Let's start with communication. Manon, you have a good experience to share.
I had a fitness to drive test and an occupational driving test, and both letters arrived at the same time. When I booked into the doctor's, I took the wrong letter. The doctor was really good and reassured me that these things happen. She helped me to book in another appointment so I could see her again. While I was there, she asked me if I needed anything or any scripts refilled. She didn't talk down to me, and she communicated normally and was friendly.
Good communication is accessible, inclusive, and effective. It improves health outcomes. Good communication is especially important for people with intellectual disability to be involved, feel comfortable, and be listened to when making healthcare decisions. Over to you, Manon.
Here are our 4 steps for good communication. Listen and receive what I have to say. Check that you understand me. Repeat back what I have said to you. Speak and express what you want me to know. And check that I understand what you have said. You can learn more about good communication and this communication model in our eLearning.
We also need to consider people who have complex communication access needs, or who use alternative and augmentative communication, called AAC for short.
Sometimes people don't use words to communicate, they use their behavior to communicate.
Sometimes the behavior of people with intellectual disability is misunderstood. Diagnostic overshadowing occurs when an assumption is made that a person's behavior is a part of their disability without exploring other factors that are involved. Imagine a man who has an intellectual disability who is taken to hospital because he is displaying challenging behaviors like shouting, self-harming, and non-compliance. The hospital staff check the man and assume that his behaviors are part of his disability, so they don't look further into his physical health. After days of worsening behavior, a nurse finally notices the man wincing when he moves. It turns out that the man has a severe dental infection, causing him intense pain, which he couldn't communicate with words. Instead, he was communicating with his behavior, which was overlooked. An important part of inclusive communication is being open and attuned to what a person communicates through their behavior.
Sometimes we need to use tools or adjust our communication to make sure that it is accessible and inclusive. Some examples of communication tools are easy read documents, social scripts, visual aids, health passports. A health passport is a summary of a person's health and inclusion needs. Let's talk about easy read. Over to you, David.
This is an example of an easy read document. Easy read uses clear, everyday language matched with images to make sure everyone understands. This easy read document is called Me and My Medication. It's a guide for people with intellectual disability to understand medication and safety around medication. Providing health information in easy read makes it more accessible for many people with intellectual disability. Providing information in easy read is recommended in the National Safety and Quality Health Service Standards. CID creates lots of easy read information about a range of topics. You can find them on our website. You can find a link to the medication guide at the bottom of this video. We have a service that can assist your organisation to make easy read documents. Our Inclusion Services team at CID is the not-for-profit business arm of our organisation. Inclusion Services offers a range of services such as translating documents into easy read training to teach people and organisations how to do easy read, focus groups to get feedback and ideas from people with intellectual disability on specific issues, easy read videos for people with intellectual disability, inclusive governance training for organisations to learn how to have inclusive boards, and inclusive practice training to learn how to work with and support people with intellectual disability in an inclusive and accessible way. You can find a link to Inclusion Services at the bottom of this video. Now let's talk about our folder. Over to you, Madeline.
We made the My Health Matters folder. The folder is a tool for people with intellectual disability to share health information with health professionals, families, and other supports. The folder has sections with personal information, including how a person communicates and how to communicate with them, medical information, including allergies, the person's key health professionals, and medical history, tools for health settings. We translated the My Health Matters folder into 12 languages: Arabic, Dari, Greek, Hindi, Italian, Nepali, Punjabi, Simplified Chinese, Spanish, Tagalog, Traditional Chinese, and Vietnamese. You can download the My Health Matters folder from our website, and you can find the link to the folder at the bottom of this video. So let's hear from Leonie about how she uses her folder.
I use the My Health Matters folder to speak up for myself. I love the folder because it means my health information is mine. I use the folder to tell my doctor, psychologist, and neurologist how I communicate and how I make my health choices. I have written in the folder about how mostly I can make my own health choices. You can use the My Health Matters folder like I have in your next health appointment. When you use the folder, I hope you feel like I do. I feel my health worker listens to me and includes me.
We would like to show you one more tool for communication. For many people with intellectual disability, it's hard to talk about health with someone you don't know. We created the My Health cards as a tool to make health conversations easier. The cards help people with intellectual disability to think about their health and prepare for health appointments. Health professionals can use the cards to facilitate conversations. Over to you, Manon.
The cards help people connect with their health professionals. There are 3 kinds of cards: connection starters, so some are serious and some are fun, cards about physical health, and cards about mental health. Here is an example of a card about physical health. This card says, "What is the most important thing about your health today?" The cards have an image and a story on the back to help explain the question. So this one says, "Maria wants to know how to eat more healthy food." Over to you, David.
There are 23 question cards in the pack. You can download the My Health cards from our website. You can find a link to the cards at the bottom of this video. Over to you, Manon.
We also have information to support First Nations people. The Let's Yarn poster includes 12 inclusive communication tips for professionals working with First Nations people with intellectual disability. The Let's Yarn fact sheet has more detail about culturally considerate communication for professionals like you. An Aboriginal health worker guide is for First Nations people with intellectual disability and their supporters to learn about Aboriginal health workers and what they do. You can find links to these resources at the bottom of this video. Over to you, David.
All the communication tools we talked about are reasonable adjustments. Reasonable adjustments are changes made to meet an individual's needs and wants so that people with intellectual disability receive the right healthcare. Reasonable adjustments are part of best practice in person-centered care and will be different for each person. Manon, can you share examples of reasonable adjustments a health professional makes that help you receive the care you need?
Some of the reasonable adjustments health professionals have made in my appointments are drawing pictures, writing notes, helping to fill out forms, using charts and diagrams to show rather than tell, showing medication packets and tablets. Back to you, David.
Reasonable adjustments might be made by health professionals or other people working in the health setting, like administration staff. Let's talk through adjustments that could be made before, during, or after seeing a person with intellectual disability. Manon, you can start.
Adjustments you can make before you see someone are contacting them to find out what adjustments they may need, booking to see them at a time that is good for them, sending appointment letters and procedure explanations in easy read, helping with forms, and showing images of spaces and equipment ahead of time. Over to you, David.
Adjustments that you could make when seeing a person with intellectual disability are having a quiet waiting space, giving the person the opportunity to have a family member or advocate with them, allowing extra time, having consistent contact staff each time the person sees you, using health passports like the My Health Matters folder, and speaking directly to the person. Back to you, Manon.
Some adjustments you can make after you see the person are reminding the person of what they need to do. Write important things down. Make referrals easy to follow up. And include information about the reasonable adjustments in the referral. Over to you, David.
We have made a checklist with more information about making reasonable adjustments before, during, and after seeing a person with intellectual disability. The checklist has links to lots of our resources. You can find a link to the checklist at the bottom of this video. You will also find more ideas and stories about reasonable adjustments in our e-learning modules. Over to you, Manon.
It is really important to make reasonable adjustments. There are lots of benefits. People have better health outcomes, so that means better treatments and better health. People with intellectual disability can fully participate in their healthcare and they are not disengaged. There are less barriers to healthcare. People can trust their health professionals. Everyone communicates better. Health professionals can meet their legal and ethical responsibilities, and people get the support and care they need. Healthcare is fair and equal for everyone. We have a question for you. What reasonable adjustments have you made in your practice? You can pause this video while you reflect. Over to you, David.
The last topic we want to talk about is supporting people with intellectual disability to make healthcare decisions and getting their consent in healthcare settings. As you know, healthcare can involve decisions that are difficult, complex, and consequential. Australia is party to the United Nations Convention on the Rights of Persons with Disabilities. The convention significantly changed our responsibilities towards decision-making for people with intellectual disability. We must shift away from substitute decision-making, which is when someone makes decisions on behalf of a person with intellectual disability. Instead, people with intellectual disability should be supported to make their own decisions. Existing law in Australia requires clinicians to obtain substitute consent if a person lacks the understanding required by law to give consent. This approach should only be used as a last resort after all efforts to support the person to make their own decisions. Self-determination is a fundamental human right. When someone decides on behalf of another person, the person's right to autonomy is denied. We want to enable supported decision-making as often as we can. At CID, we've made a framework for supported decision-making. Over to you, Manon.
We want to share part of that framework with you. These are called decision maker statements. These statements are at the heart of putting supported decision making into practice. Each statement is something that a person with intellectual disability can say when they are making their own decision. The statements draw attention to their decision-making rights, and as their health professionals, they need you to hear and support them. There are 8 statements. I can change my mind. I can try. I can make mistakes. Listen to me. Give me the information I need. It is my life. Give me the support I need, and I can decide. Back to you, David.
You can keep these statements in mind when you are supporting a person with intellectual disability to make a decision. The statements can be complemented by inclusive attitudes and beliefs. You can start from the assumption that the person with intellectual disability is capable of making decisions and providing consent. Provide information, engage with the person, and avoid speaking to others on the person's behalf. Start from the assumption that the person with intellectual disability has the capability to understand the information provided, and take the time to make that information and ideas accessible. Suspend judgments about the person's quality of life. It's important not to express fear, pity, or a reluctance to provide the person with care. You can find more information about supported decision-making at the bottom of this video. Manon, can you describe a time when a health professional helped you to make a decision?
When I was 23, I went to the GP for period pain. I had already done lots of tests to try and figure out what was wrong. I did not want any more tests. I just wanted pain relief that worked. The GP listened to me and suggested medication that would help. He explained what the medication would do and the side effects it could have, and this gave me all the information I needed to decide if I wanted to take this medication. The medication really helped and made a big difference for me. Back to you, David.
Thank you for sharing your experience, Manon. Can you tell us why it's important for health professionals to seek your consent and for you to make your own decisions about your health and healthcare?
It is important because I am an adult. I have the right to make my own decisions. It is my health. Back to you, David.
If you would like to learn more about the topics that Manon and I have covered today, we encourage you to complete our Just Include Me eLearning. The eLearning covers key topics for inclusive healthcare with modules on identifying and meeting a person's communication needs, determining and applying reasonable adjustments in healthcare, understanding behaviour as another form of communication and responding accordingly, ensuring accessibility when providing care virtually or by telehealth, and supporting people with intellectual disability to make decisions about their health, including consent for care. Just like this workshop, the voices and experiences of people with intellectual disability are the focus of the e-learning. The e-learning also includes links to many more great inclusive resources offered by CID. The e-learning is free, and you can complete it on the HETI or Medcast platforms. The e-learning is self-paced and takes approximately 2.5 hours, which can be accredited for CPD. The modules are formally accredited with the Royal Australian College of General Practitioners and the Australian College of Rural and Remote Medicine. We encourage you to undertake our e-learning as a way to continue strengthening your person-centered practice and for you to continue championing the rights and health of people with intellectual disability. You can find a link to the e-learning at the bottom of this video. We are expanding our e-learning to add 2 modules on unconscious bias. Unconscious biases are attitudes or stereotypes that unconsciously alter our perceptions or understanding of our experiences, thereby affecting our behaviour, interactions, and decision-making. Although bias is human nature and not anyone's fault, we must learn and practice skills to prevent it from affecting clinical decisions. The new modules are about understanding unconscious bias and its impact on healthcare, particularly for people with intellectual disability, identifying common types of unconscious bias and how they can influence attitudes, behaviour, and decision-making, reflecting on personal attitudes and behaviours to identify and challenge unconscious bias. Keep an eye out, CID will be launching the new modules in late 2026. Over to you, Mel.
We have 2 questions for you. What stood out for you today? And what could you see yourself using in your work? You can pause this video while you reflect. Over to you, David.
If you enjoyed this workshop and know someone who would benefit from watching it, please share it with them. All of our resources, including the eLearning, My Health Matters folder and My Health cards, can be accessed for free from our website, cid.org.au. Over to you, Mel.
We'd love to hear from you. Our contact details are on the screen. Thank you for joining us. Thank you for your time and interest. Thank you for all your important work. We appreciate your desire to be champions for inclusion.
Thank you.
Thank you.